Thanks, Murray, and welcome everyone today. I'm going to try to talk from the slides, so I might be turning a little bit to the right. What I'd like to do today is hopefully provide you with some information about some of the concepts that underpin what we're doing in rehabilitation to make the point that it's not completely empiric and completely mad what we're doing sometime. Usually in situations like this, I find that I'm getting more advice from caregivers rather than actually providing you with advice, because you are really in the real world in taking care of people with dementia. Where's the, is this it? Yep. This one. There we go. Oops. Anyway, the bad news first. The bad news first is we're all getting old. We get wiser as we get older. But when you look at function and in rehabilitation, when we discuss function, we're really talking about those mundane things one needs to get through everyday life, like getting up and out of bed, toileting, eating, dressing, getting out the door, going to work, paying bills, driving a car. And in spite of decreased function with normal aging, there seems to be a disproportionate loss of function in people with dementia. And this is an example of one of several studies which have been done across the world in a group of Swedish subjects with dementia who were followed over a 7-year period. 31% were severely disabled in personal care at baseline or at the beginning of the study, and then over 7 years, 68% became severely disabled. So the loss of function becomes inevitable with a neurodegenerative process. One of the concepts which we talk about in rehabilitation is inactivity. And the astronauts have really taught us a lot about inactivity, in that when people are in gravity-limited environments for prolonged periods of time, extrapolate that to having a sedentary lifestyle or being bed rest after you're sick, there are certain negative physiologic things which occur. The heart becomes weak, the muscles become weak, and we don't like inactivity in rehabilitation. And some would argue that most of what we actually do in rehabilitation is reverse the physiologic inactivity effects. There's a new line of research and investigation which the astronauts from NASA have not taught us, because even though their bodies may be relatively inactive in gravity-eliminated environments, they're cognitively very busy performing experiments in space. So there's a recent study by Verghese and colleagues which supported that higher levels of activity of engagement in cognitive activities as one grows older can be viewed as an intervention to modify cognitive activity as a risk factor. So the thinking is that cognitive inactivity is a risk factor for developing dementia. They studied a large group of people over 21 years, at median over 5 years. 121 of these 469 subjects developed dementia, and higher levels of participation in leisure time activities such as reading, playing board games, playing musical instruments, and dancing was associated with a lower risk of developing dementia. In a similar and parallel line of investigation, Ball and colleagues reported the results of the active trial. This was a multi-center, gold standard type of clinical trial in medicine that studied intact elderly people. It assessed the outcomes prospectively after exposure to cognitive remediation treatments in 3 cognitive domains: verbal memory, verbal reasoning, and visual motor speed of information processing. The outcomes of these 3 treatment groups were compared to those of a control group. Significant improvements in cognitive performance were observed in all 3 treatment groups after exposures to the interventions, and importantly, these gains were sustained over 2 years. So these types of studies suggest that cognitive activity and even mental exercises may contribute to optimizing neural reserve in intact elderly people, and it's important to make that distinction. In contrast, conceptualizing the brain as a mental muscle, requiring cognitive exercises to enhance or maintain cognitive functions in those with dementia, has really received little empiric support. Cognitive neuroscientists have proposed that cognitive remediation learning strategies that are too attentionally demanding and that require learning mnemonic approaches that are expected to become internally generated, and the classic strategy is using visual imagery, are not useful for enhancing learning in those with dementia. The good news, and the rest is the good news. is that there are cognitive neuroscientific concepts available to guide learning for those with dementia. So the first concept that we need to distinguish is distinguishing the learning what from the learning how system. Limitations in the fundamental attentional functions of dementia may impair one's ability for conscious learning. That is also known as an explicit or declarative learning system, it's been called. And it's the learning what system, and it's remembering facts, remembering people's names, remembering places, remembering the time of day. Often these are things you don't need to get through the day. Unconscious systems of learning may be available to support learning in those with dementia. These systems of learning are also known as implicit or procedural learning, and we call them the learning how system. They are minimally dependent on the use of attentional resources. The best example of learning within these systems includes conditioned learning, so one of the classic forms of behavioral management, and motor skills learning, which is much of what we do traditionally in rehabilitation. So it doesn't matter that you know what your therapist's name, but it matters that you remember, if you're someone with vascular dementia, how to put your new prosthesis on, how to modify your dressing activities as a new amputation, for example. It is thought that the learning what system is disproportionately impaired in dementia, and that the learning how system may be able to support learning. Moreover, the more severe and or more progressed is the dementia, the more dependent one is on implicit or unconscious memory systems to support learning. Implicit or procedural memory and learning strategies are being applied to facilitate learning in those with dementia. And the best study is a behavioral management strategy called Errorless learning. Errorless learning, which was developed by Baddeley in England, the concept offers those with dementia a strategy to manage error making during the course of learning. The to-be-learned information is presented to the cognitively impaired individual in a manner to avoid or minimize mistakes and to reduce an anxiety-provoking learning experiences created during trial and error learning and more traditional Socratic learning. So it's really a more nurturing style of learning, certainly not the way of learning in most medical schools in this day and age. The nurses do better at the errorless learning than the doctors. This newly acquired information is then collaboratively rehearsed in a manner to avoid a negative experience. Positive feedback is provided when a target task is performed correctly. A neutral response follows erroneous behavior that is then linked to providing essential information and participating in the desired behavior in a non-didactic manner. Essentially, it's good behavioral management. Reward the positive or desired behavior and ignore or have a neutral response to the negative or undesired behavior. Memory intact individuals have available to them cognitive operations such as selective attention, being able to inhibit or disengage from certain information in the environment that will minimize the influence of making mistakes on learning, and we even say may learn from their mistakes. Those with impaired conscious learning or explicit memory, such as those with dementia, exposure to errors brings unnecessary attention to them, it is thought, and this serves only to reinforce them. Thus, errorless learning provides an externally applied strategy within physical, occupational, speech therapy situations that intends to prevent an experience of making errors that are detrimental to learning. The best study of errorless learning strategies have been done by Claire and colleagues. Linda Claire is a colleague of Barbara Wilson, who's known in cognitive neuroscientific circles as a guru of rehabilitation of memory and cognitive impairments. These studies have demonstrated their best outcomes during trials of face name learning, that is, learning the proper names of people of whom one is in regular contact with during everyday life. And they, for example, studied people who were involved in an adult day program, so it was the target task was to learn the names of the other clients as well as the staff members. And they studied people who had dementia who were members of a social club, and again, the target task was to try to remember the names of the other clients at the social club. To a large degree, the ability to sustain over time what has been learned after an intervention phase, which usually lasts anything from 6 weeks to 3 months, was dependent on practice that was usually directed by a caregiver. So the caregivers are not unimportant in the world of cognitive remediation. In fact, extremely important. The intervention phase in practice during face name learning usually involved using photographs to begin and then trying to generalize this with rehearsing remembering people's names during meaningful and real interactions. Other skills which have been subjected to errorless learning approaches in those with Alzheimer's dementia have including using external aids such as a daily planner, a calendar, electronic pager. These are fairly classic in the world of rehabilitation of cognitive impairments for people with traumatic brain injury and stroke. The outcomes have been variable when observing whether there was a decrease in the rates of repeated questioning that was directed toward caregivers. So these external aids, the hope was that if people could learn how to use them, there would be less repeated questioning during the course of the day to the caregiver. Again, the success of using these aids was dependent on whether the caregivers reinforced what one learned with ongoing and practical practice and rehearsal. Several other implicit or procedural learning approaches have been studied in those with dementia. These have been directed toward either relearning automatic motor skills that support taking care of oneself or support mobility in everyday life, as well as some new skills learning. So there's 2 Italian studies that investigated what they called procedural memory stimulation. This is basically what we do in rehabilitation all the time. It's using the previous experience of the subjects, but without conscious recognition, to enhance or fine-tune performance of personal care, activities, and household chores. Functional performance training occurred within structured occupational and physical therapy sessions, one-on-one training sessions over several weeks. So it's a sort of a good natural history study of studies of what happens in formal rehabilitation. Group comparisons between subjects who were assigned either to a treatment group or to a control group demonstrated significant improvements in time performance of target skills and functional status immediately after the intervention phase in treatment. Unfortunately, these were not consistently sustained over months, so once the active treatment or the directed treatment was pulled back, people did not sustain these gains, and this again is something that's fairly consistently observed in everyday life of rehabilitation. 2 other interesting types of studies. One is a motor skills study by Rosler, looked at 5 Alzheimer's dementia subjects and 5 age-matched depressed subjects who received training over 12 days in learning how to do the waltz. The outcome measures implicit learning skills, so sense of rhythm, how one expresses in movement, fluidity or smoothness of movement, creativity and use of space in comparison to what they called explicit learning skills, the number of learned steps, and there was a disproportionate improvement observed in the implicit learning skills rather than the explicit learning skills, the number of new dance steps learned for the patients or subjects with Alzheimer's dementia. I want to talk about this last study by Cott because it sort of challenges a long-standing literature that has supported that exercise helps cognition in people from a variety of diagnoses, including dementia. They applied a dual task paradigm, basically a multitasking or doing 2 simple things at once to observe its effect on communication skills and walking abilities, as well as overall functional status. They studied clients in nursing homes who were randomized to 4 subgroups: walk and talk in pairs, walk and talk in groups, talk only, and no treatment. The walk and talk in groups demonstrated significant decrease in functional status after the intervention phase. This was not a desired result, but in speculating these findings, which really do dispute a line of investigation that has observed more generally a positive influence in exercise on cognition, suggests that the application of such a dual task paradigm was essentially too complicated. That within a group context with more an open-ended interactional style, it actually may be deleterious to learning. So the next concept or point to make is that the context of learning is important in dementia. And there's been a very creative group of studies by this group from University of California, Irvine, that looked at motor learning, both gross and fine motor learning. They used an underhand toss task and I think a rotatory pursuit task. When the Alzheimer's disease subjects and the healthy controls were compared during these experiments, distinct differences in their patterns of learning and their ability to generalize to related tasks were observed. Motor learning occurred best in the Alzheimer's disease subjects when the learning conditions were uncomplicated, highly structured, consistent over time during the practice and rehearsal, and that is that they were the least attentionally demanded. Generalization to perform a related task was rare in that the learning was hyper-specific for a target task. So good example is learning how to use a cell phone does not generalize well to learning how to use the remote control on the television. Learning how to use the remote control on one television set does not generalize to use a remote control on another television set. And the point is that the task learning is really heavily dependent on the environmental cues. Healthy subjects, on the other hand, learn best and generalize well to related tasks when the learning conditions were complex, so messier, less structured, variable, and had higher attentional demands. Are there dementia-related behaviors that indicate that learning capacities are finite? So when is learning limited is the answer, or the question, excuse me. We may have an answer. We're starting to get an answer. And that the rehabilitation of treatments are best directed toward the caregivers and those with dementia. And part of your everyday lives knowing this is that there are an array of behaviors that we sometimes refer as different frontal lobe syndromes or part of some frontal lobe syndromes that are clearly counterproductive in learning situations in those with brain diseases, including dementia, such as poor insight into one's difficulties or deficits, passivity, apathetic behavior, poor initiation, anger, verbal or physical abuse, repetition, perseveration, and impulsivity or disinhibition. Alderman has studied a group of people who are behavioral management non-responders. He has proposed that impaired ability to learn itself as a reason for non-response to behavioral management. He has suggested that despite the presence of non-productive and obstructive behaviors, there are actually more fundamental and critical neuropsychological operations that, if impaired, will predict a finite learning ability. Specifically, what are termed the impairments in the central executive of working memory. So a new concept which I'll try to define for you. What is implied is that difficult behaviors should be able to be controlled with behavioral management strategies. We have a lot of experience with this in the traumatic brain injury and in the stroke world. We do need our medications. Let us not minimize the use of neuromodulating medications. So Alderman compared age and intelligence matched control subjects to two groups of non-aphasic brain injured patients. So here we're, and what we've done a lot in the world of dementia is extrapolate what we've learned in stroke and traumatic brain injury. 10 who responded to behavioral management for difficult behaviors and 10 who were categorized as non-responders. The group of behavioral management non-responders significantly and disproportionately demonstrated impaired performance on probes of the central executive of working memory as classically measured by dual task paradigms. These findings suggest that impairment in a critical cognitive operation rather than disease severity, degree of cerebral involvement, or even demonstrated behavior may identify those with brain disease who are resistant to behavioral management and thus may have a finite learning capacity. What is working memory? Murray hates when I use this term, but I use the term, it's cognitive infrastructure. It's a concept developed by Baddeley over the last 25 years that defines a model of short and long-term memory that is consciously and intentionally driven. It is a cognitive operation that is fundamental and determines online what bits of information we need to perform any higher level cognitive operation. It controls long-term memory, controls short-term memory, and in the world of rehabilitation, higher cognitive operations are things like eating, toileting, and dressing. These are not uncomplicated tasks. Finally, we want to ask how caregivers can be productively incorporated into rehabilitation treatments of those with dementia. And I guess the good thing is that the word dementia and rehabilitation are actually being discussed in the same context, which 10 and 15 years ago was not always the case. Rehabilitation as a philosophy does not separate the individual with dementia and the caregivers during treatments, in that the caregivers really determine the physical and the interpersonal environments of the individual with dementia. As I think we've articulated, the success of most treatment interventions is dependent on channeling the practice and application of newly acquired and required skills through the caregivers. However, the social and emotional contexts around learning and behavioral management in dementia must be considered. The most creative treatment approaches will become meaningless when caregivers are unavailable, overwhelmed, burned out, disinterested, unable to abandon long-standing, automatic, and counterproductive emotional responses to difficult behaviors. So obviously the demands are high And so the question is, what is really being done to help modify or rectify and support the caregivers? There's actually quite a huge literature on this. Most of it is old, but there's some more interesting studies that have really been done more rigorously. This group of investigators studied a progressively lowered stress threshold intervention on caregiver Alzheimer patient dyads. The intervention was directed at decreasing problematic behaviors among the demented individuals, these being stress-inducing within 6 categories: fatigue, changes in routine, changes in environment, changes in caregiver, internal external demands of the environment, or internal demands that exceed one's real functional abilities, and multiple competing stimuli in the environment, as well as impaired physical status. The group caregivers were taught interpersonal and environmental strategies to operationalize stress reduction within the home. The most interesting finding of this study was that positive outcomes varies as to which family caregiver, in relation to what outcome, or whether the family caregiver was a spouse or not. So the difficult or problematic behaviors became less among the demented individuals within the subgroup who had non-spousal family caregivers, typically an adult daughter. Functional status improved within the subgroup of spouses who had the caregivers. So there's some interesting questions in there. Claire and colleagues explored dementia individual family caregiver dyads during training of caregivers in cognitive remediation when looking at cognitive remediation strategies. Among the concepts being probed in this study was whether placing the caregiver in an explicitly therapeutic role added to the stress of the caregiver, and whether this translated into anxiety, depression of the demented individual. Of course, the observed outcomes demonstrated less anxiety and depression among the demented individuals, but increased caregiver strain after 6 months. Hello, yeah. Under rigorous investigation. Local resource is Laura Gitlin, who's a PhD occupational therapist at Jefferson, has really done a series of interesting multi-city trials. Philadelphia is one of the sites. They've looked at a home environmental skills building program within REACH, National Institutes for Health Resources of Enhancing Alzheimer's Caregiver Health. As mentioned, it's a multi-city trial that uses occupational therapy, home-based interventions aimed toward education of caregivers and environmental modification. The caregiver education encompassed teaching, reinforcing skills to support autonomy in daily life, not only of the client or what I would call the patient or subject, but also of the caregiver. Management of difficult behaviors by providing emotional support, stress management, coping strategies, skills training. So what you're seeing in these caregiver trials is that there's an eclectic and multidimensional approach to the interventions. Over 6 months, decreases in caregivers receiving help from family and friends was significantly less, so they were actively facilitating that the caregiver provided personal care to the individual with dementia. Not that getting help from family and friends is such a bad thing to happen, to be decompressed. There was significantly less upset with difficult behaviors by caregivers, and significantly improved affect of the caregivers was reported. This is at 6 months. At 12 months, the positive outcomes were not maintained, except that the caregiver affect continued to improve. And this study is currently in process. I haven't seen that the 18-month follow-up data have been 5 minutes. Last slide. Investigation of caregivers and rehabilitation. The other interesting observation of this Gitlin group of studies is that African American caregivers demonstrated more positive aspect of caregiving, possibly related to higher religiosity, lower anxiety, lower upset at baseline in tolerating difficult behaviors, and lower socioeconomic status. In summary, what needs more study is whether there are critical cognitive operations that tell us when learning is finite. Cognitive inactivity we're viewing as a risk factor for developing dementia. Therapists are beginning to have an organized repertoire of behavioral assessment and treatment skills that are admittedly labor-intensive on which to guide treatment, including errorless learning and the conscious-unconscious learning dichotomy. Procedural learning in those with dementia tends to be hyperspecific, so we really don't understand the basis of poor generalizability to related skills. Difficult behaviors can be reduced and learning can occur with behavioral management strategies that are taught to caregivers. Caregivers are receptive to learning these strategies. Yes, knowledge is power. The studies that combine the use of medications with behaviorally based treatments aim toward delaying terminal phases of finite learning have not yet been done. Thank you.